Welcome to the Deep Dive. Today we're tackling um, really one of the most important and maybe challenging aspects of the incredible success we've actually seen in cancer treatment over the past few decades.
Right.
We've become so much better at curing cancer, getting patients through that initial diagnosis, the intense treatment, and that is a triumph worth celebrating.
Absolutely. It's huge.
But it's also created this kind of new reality. The battle, well, it often doesn't end when the treatment does. For millions, it shifts focus to managing the long-term impacts of the very therapies that save their lives.
That's absolutely right. The narrative around cancer has, rightly focused on survival rates, on beating the disease. But as that survivor population grows, we're increasingly confronted with the complex truth that the journey continues.
Yeah.
And often it involves navigating pretty significant health challenges that can arise months, years, or even decades after treatment actually concludes.
So this deep dive, we're dedicating it entirely to understanding this landscape, right? And we're drawing specifically from the rich detail in Chapter 95 of our source material.
Exactly. That's the plan.
And our mission here, given the depth of this source, is to really go beyond the surface level. We're aiming to understand this topic with the kind of detail and nuance that, the professionals who work in this field day to day really need to grasp.
Getting into the weeds.
Yeah, we want to dissect not just that these lasting effects occur, but delve into the specific ways different treatments impact different organ systems over time.
Yeah.
It's about gaining a comprehensive, almost, professional level understanding of what survivorship truly entails beyond just the absence of cancer.
And the source material makes it clear right from the start how significant this is. It highlights that the impact of cancer stretches well past the initial diagnosis and treatment period. Patients are significantly affected by these treatment-related toxicities that can extend far beyond that initial phase. And it gives a really sobering statistic right at the beginning, one that underscores the magnitude for a particularly vulnerable group, adult survivors of childhood, adolescent, and young adult cancer.
Okay.
These individuals who survived cancer early in life, they face substantial long-term health consequences, partly related to what's described as premature physiological aging and frailty brought on by the treatment itself.
Wow. Premature aging.
Yeah. The source reveals that more than 40%, over 40% of these survivors will go on to face a severe, disabling, or life-threatening condition, or tragically even die from a chronic condition directly related to their past cancer treatment.
40%. That's not a small subset at all.
Yeah.
That's nearly half facing major life-altering health issues because they survived cancer.
Precisely.
That one statistic alone tells you why this topic isn't just important. It's a major public health and clinical challenge right now. And the force gives us some crucial language to distinguish these issues, doesn't it?
It does. It defines long-term effects as those toxicities that emerge during the active therapy and then persist beyond its completion.
Okay, so they start during treatment and just stick around.
Exactly. Whereas late effects are the ones that may not even show up for months, years, or in some cases, many, many decades after treatment has finished.
That distinction feels really key. It highlights the need for lifelong vigilance, doesn't it?
It absolutely does. It's not enough to just monitor a survivor for a few years post-treatment and say, okay, you're good. The late effects can be, insidious, developing long after the cancer itself is gone.
Yeah.
And the source introduces a perspective that can sound quite stark. It describes the management of these long-term and late effects as, in a sense, a privilege afforded to those who survived the primary disease.
A privilege. That's a powerful way to put it. Almost confronting.
It is. These are problems faced because the treatment was successful, because they survived. But, and the source immediately emphasizes this framing in no way diminishes the critical importance of understanding, managing, and actively addressing these issues with the full force of medical knowledge and resources.
Right. It doesn't make them less serious.
Not at all. It is fundamentally a challenge born of medical success.
A challenge we are now, hopefully, equipped to understand in greater depth. And the scale of this challenge is only growing, right? The numbers in the source about the increasing survivor population are quite compelling.
They really are. The source paints a clear picture of a rapidly expanding survivor group. In the U.S., for instance, the number of people alive after a cancer diagnosis is projected to grow significantly.
How significantly?
Well, from about 17 million currently to nearly 26 million by the year 2040.
Wow, 26 million.
Yeah, and even looking shorter term, the number surviving at least 5 years post-diagnosis. That's expected to jump by 35% over just the next decade.
35% increase in just 10 years.
It shows this isn't a static population. It's dynamic, it's growing. It represents a huge success in treatment, absolutely. But it also means we need this massive ongoing shift in healthcare focus towards survivorship care.
And this growth, it's a direct result of the incredible strides we've made in actually treating cancer.
Right.
We've seen remarkable improvements across the board: surgery, radiation, standard chemo,
Mm-hmm.
but also the newer kids on the block, targeted agents, immunotherapy. These advances have pushed survival rates way up. The source mentions things like over 80% 5-year survival for childhood and adolescent cancers now.
Which is fantastic news. But, and this is the crux of our discussion, while these treatments are more effective at getting rid of the cancer, they each come with their own unique set of long-term and late effects.
Exactly. So it's like we've solved one problem or gotten much better at it, but revealed another layer.
Precisely. We've had decades, really, to study the long-term impacts of older agents like, say, anthracyclines or radiation to specific body areas. Their toxicities are relatively well characterized, though still serious.
We kind of know what to expect, or at least what to look for.
To some extent, yes. However, the widespread use of newer targeted therapies, which are often given not just for a few cycles, but indefinitely, like a chronic treatment.
Right, for years sometimes.
Exactly. That's introducing entirely new patterns of cumulative toxicity and late effects. And the source notes that sometimes the full spectrum of these effects, and even their definite causal link to the drug, only becomes apparent years after a drug is approved and used in large populations.
So we're learning as we go, in a way.
In a way, yes. It really underscores the vital need for robust pharmacovigilance, ongoing monitoring after approval and long-term follow-up studies.
It feels like our ability to treat is maybe outpacing our complete understanding of the long-term consequences sometimes.
That's a fair point. The source points out that despite the sheer scale of the cancer survivorship population and the magnitude of these late effects, the field remains, well, notably understudied compared to acute cancer treatment research.
Really? Even with millions of survivors?
Yes. A significant chunk of the research that does exist is observational or descriptive. It tells us what problems survivors are facing.
Okay.
But there are fewer studies dedicated to how to effectively prevent or treat these specific complications once they arise.
So we know the problems exist, but not always the best solutions yet.
That's a critical point the source emphasizes. There's an acknowledged gap in our understanding of the underlying biology, what's actually driving these long-term toxicities at a cellular level. And how does a patient's individual genetic makeup maybe predispose them to certain effects?
That genetic piece sounds crucial for the future.
It really is. Gaining a deeper biological and genetic understanding is essential to move towards hopefully identifying patients at highest risk before treatment and potentially developing more personalized prevention or intervention strategies down the line.
And for the oncologist actually treating patients, there's this inherent tension, isn't there? This balancing act the source talks about.
Oh, absolutely. Their primary goal, especially when there's a chance for a cure, has to be disease control, eradicating the cancer.
That makes sense. You have to win the immediate battle first.
Precisely. The source emphasizes that the fear of potential long-term complications, even serious ones, shouldn't be the deciding factor that prevents giving the most effective, potentially curative treatment for the cancer itself.
So you don't hold back on treatment just because of potential late effects?
Generally, no, not if it compromises the chance of cure. As we discussed, managing the late effects is, in that stark framing, a privilege of survival. The immediate priority is the cancer. But, and this is key, once that initial battle is won, the clinical and research focus absolutely must pivot with equal intensity to addressing the consequences of that successful treatment.
Okay.
And to really understand that, we need to dive into the specifics, the specific organ systems that bear the brunt of these long-term impacts, as the source details so meticulously.
Okay, let's do that. Let's unpack this complex landscape organ system by organ system using Chapter 95 as our guide. Where should we start? Maybe the heart. The cardiovascular system seems highlighted as a major area of concern.
It is indeed flagged as a particularly significant issue, especially for survivors treated when they were young. The source states, quite starkly, that cardiovascular disease is the most common cause of non-cancer death in childhood cancer survivors.
The most common cause of non-cancer death. That's sobering.
It is. And to put a number on it, there's a striking statistic. An estimated 1 in 8 childhood cancer survivors will experience a life-threatening cardiovascular event within 30 years of their initial treatment exposure.
1 in 8. That's a substantial lifetime risk accumulating over decades.
It absolutely is. It really brings home the scale of the problem long after the cancer is gone. And the source clearly identifies specific treatments with these well-characterized cardiovascular risks.
Right, the usual suspects.
Yes, the two main culprits historically have been anthracycline chemotherapy drugs like doxorubicin.
Adriamycin, yeah.
Exactly. And a radiation therapy that involves the mediastinum, which is that area in the chest containing the heart.
Okay. And what kind of heart problems can these cause?
A whole range, unfortunately. Arrhythmias, abnormal heart rhythms, cardiac ischemia, which is reduced blood flow to the heart muscle, congestive heart failure, or CHF, inflammation of the heart's outer lining, pericardial disease, or the muscle itself, myocarditis, and even peripheral vascular disease affecting the limbs.
Let's tackle radiation first.
Yeah.
How exactly does radiation damage the heart muscle and surrounding structures?
Well, the source explains that radiation can cause fibrosis, essentially scarring within the heart muscle tissue itself. That's called interstitial myocardial fibrosis.
Okay, scarring in the muscle.
Right. It can also lead to inflammation of the sac around the heart. This can be acute pericarditis, which shows up relatively soon after treatment, or it can be chronic constrictive pericarditis, which develops much later, often years later, and is more serious because it restricts the heart's movement.
So inflammation early or late and scarring. What else?
Radiation also damages the heart valves. This can lead to problems like aortic insufficiency or mitral regurgitation, where the valves don't close properly and leak.
Leaky valves.
Yes. And maybe most concerningly long term, it can significantly accelerate the process of atherosclerosis, the hardening and narrowing of arteries, particularly in the coronary arteries that supply blood to the heart muscle itself.
Which increases heart attack risk down the line.
Massively. This risk is definitely higher with higher doses of radiation. The source specifically notes doses greater than 6,000 centigrade, or CLIP-G, as being particularly problematic.
6,000 CLIP-G, is that considered a very high dose in radiation therapy?
It is a substantial dose, yes, especially delivered to that region. The risk is also increased if cardiotoxic chemo was given around the same time, or if large areas, extensive fields of the chest were irradiated, covering more of the heart and surrounding vessels.
What's the typical timeline for these radiation effects? You mentioned acute versus chronic pericarditis.
Right. Acute pericarditis can develop relatively early, maybe peaking around 9 months post-treatment, causing symptoms like shortness of breath, chest pain, fever. But the chronic constrictive pericarditis, that thickening and tightening of the heart sac, that tends to develop much later, often 5 to 10 years after the radiation.
5 to 10 years later, wow.
Yeah. And valvular damage can also manifest later. The accelerated coronary artery disease and peripheral vascular disease from extensive radiation fields significantly increase the long-term risk of fatal heart attacks or thromboembolic strokes, often decades after treatment.
Are there ways to reduce this radiation risk to the heart? I know techniques have improved.
They have. The source notes that careful radiation planning is absolutely essential. Techniques that limit the volume of heart tissue actually included in the radiation field are key.
Like shaping the beams more carefully.
Exactly. Newer techniques like 3D conformal radiation or proton beam therapy allow for more precise targeting of the tumor and theoretically should spare more normal tissue like the heart.
But do we know for sure they reduce long-term heart problems?
That's the caveat. The source notes that while these newer techniques are promising, the extent to which they truly decrease the long-term cardiovascular effects compared to older methods isn't yet fully established in long-term studies. We need more time and data.
Okay. Now let's switch to the other major player anthracyclines, like doxorubicin. The source calls their effect dose-dependent myocardial toxicity.
Yes, that's the key phrase. Anthracyclines cause direct damage to the heart muscle cells themselves, the cardiomyocytes. The source mentions a specific finding you might see on a heart biopsy called myofibrillar dropout.
Myofibrillar dropout.
Which it describes as pathognomonic, meaning it's a very specific characteristic sign of this particular type of injury.
So if you see that, you know it's likely anthracycline damage.
Pretty much. The fundamental problem seems to be chemical-free radical damage. These molecules formed by the drug interacting with iron F3 plus doxorubicin complexes essentially attack and damage vital parts of the heart muscle cells.
Like what parts?
Things like the cell's DNA, the cell membranes, and the mitochondria, the energy powerhouses of the cell. There's also research suggesting an enzyme called topoisomerase IIB might play a role in how this damage happens.
And it's dose-dependent, you said.
Clearly dose-dependent. The risk of developing congestive heart failure from anthracyclines is definitely linked to the cumulative dose, the total amount someone receives over their entire treatment course.
Is there a threshold dose where the risk really jumps?
The source mentions a risk of about 5% for CHF at cumulative doses above 450-550 milligmeter, that's milligrams per square meter of body surface area. But, and this is really important, the source stresses that heart failure can occur even at substantially lower doses in some individuals. It's not an absolute threshold.
So even lower doses aren't risk-free.
Yeah.
And this type of heart failure sounds particularly bad.
It is. The source highlights that anthracycline-induced heart failure is often irreversible and carries a high mortality rate. It doesn't tend to get better on its own.
Which makes prevention absolutely crucial.
Exactly. Prevention is key. Researchers are looking into genetic differences, polymorphisms, that might predict who's more susceptible. But right now, our ability to use genetics for individual risk stratification is still pretty limited.
So we can't easily test someone beforehand to see if they're high risk.
Not reliably, no. But the source does mention that how the drug is given seems to matter. Giving it as a continuous infusion over a longer period, or using a liposomal formulation where the drug is encased in a kind of fatty bubble.
Liposomal doxorubicin.
Yeah, that seems to be associated with less cardiotoxicity compared to giving it as a rapid IV push.
Okay, so administration method matters. How is this monitored while patients are getting these drugs?
Standard practice is to get a baseline echocardiogram that's an ultrasound of the heart before starting anthracyclines.
To see what the heart looks like initially.
Right. Then, if a patient develops any symptoms suggesting heart failure during treatment, shortness of breath, swelling, fatigue therapy is typically held immediately, and testing is repeated. For patients who are asymptomatic but have other risk factors, periodic surveillance with echo or other functional cardiac tests during therapy is also often done.
Got it. Now, beyond the classics of anthracyclines and radiation, newer targeted therapies and immunotherapies are a huge part of cancer treatment now. Do they bring their own cardiovascular risks?
They absolutely do, and they've introduced some new patterns of risk, and importantly, they're extending these concerns to older patient populations as well, not just childhood survivors.
How so?
Well, take the small molecule inhibitors, particularly the tyrosine kinase inhibitors, or TKIs. These are often given continuously for very long periods, sometimes indefinitely.
Right. Maintenance therapy?
Exactly. That introduces new possibilities for cumulative long-term effects that we didn't see as much with finite courses of traditional chemo.
What kinds of heart risks are we seeing with these targeted agents, the TKIs and others?
The source lists several significant ones. Congestive heart failure, again, various types of abnormal heart rhythms, both atrial and ventricular arrhythmias, prolongation of the QT interval on an EKG.
Which can lead to dangerous rhythms.
Exactly. And also both pulmonary hypertension, high blood pressure in the lungs, and systemic hypertension, high blood pressure throughout the body.
That's quite a list.
Mm.
Are there specific drugs the source calls out?
Yes, it provides quite a few examples associated with CHF, including lapatinib, ponatinib, bosutinib, dasatinib, nilotinib, pazopanib, axitinib, trametinib, sunitinib, carfilzomib, and sorafenib. It's a growing list.
It really is. And the source mentioned something about black box warnings being added later for some of these.
Yes, that's a critical point illustrating how these effects can emerge late. Lapatinib and ponatinib are specifically cited as examples where serious cardiovascular toxicity led to black box warnings being added to their prescribing info a median of 4 years after the drugs were initially approved.
4 years later, that really highlights the need for ongoing monitoring.
It absolutely does. Ongoing pharmacovigilance and studying long-term outcomes are vital, even after a drug is on the market. The source also lists agents commonly causing systemic hypertension, especially those targeting the VEGF pathway, like bevacizumab, cabozantinib, lenvatinib, nintedanib, but also ponatinib and trametinib.
Okay. Any others linked to specific issues?
Dasatinib is particularly noted for its association with pulmonary hypertension, and ibrutinib is linked to both atrial and ventricular arrhythmias. As the uses for these agents expand, the source really emphasizes the growing importance of incorporating monitoring for these specific long-term and late effects into routine follow-up care, not just by oncologists, but cardiologists and primary care providers too.
It needs a team approach.
Yeah.
What about the immunotherapy agents? Well, checkpoint inhibitors, CRK therapy, any heart risks there?
Yes, definitely. Immune checkpoint inhibitors work by taking the brakes off the immune system so it can attack cancer.
Right.
But sometimes that revved up immune system can attack healthy tissues instead, including the heart.
So autoimmune heart problems.
Essentially, yes. This can lead to issues like pericardial disease, vasculitis, inflammation of blood vessels, and importantly, a potentially life-threatening inflammation of the heart muscle called fulminant myocarditis.
Fulminant myocarditis sounds serious.
It is very serious. The source notes this is thought to be a T-cell-mediated toxicity caused by specific immune cells, and it often responds to early treatment with steroids, glucocorticoids. But it can be severe or even fatal if it's not recognized and treated promptly. The risk is also higher when combination immunotherapy regimens are used.
Okay. And CAR-RT therapies.
CAR-T therapies, where a patient's own T cells are engineered to fight cancer, are associated with something called cytokine release syndrome, or CRS.
CRS, yeah, I've heard of that. It's a big inflammatory response.
Exactly. And that systemic inflammation can be severe and can cause arrhythmias or decompensated heart failure. The source mentions that blocking a specific cytokine, IL-6, with receptor blockers can help decrease the severity of CRS, and current guidelines recommend using them early in severe cases.
So, managing these treatment-related heart problems sounds pretty complex, depends on the cause. What's the general approach?
The source says that, in principle, managing treatment-associated cardiovascular disease is similar to managing other kinds of heart disease. But the crucial first step, if it's possible and safe from the cancer perspective, is to discontinue the offending agent.
Stop the drug causing the problem.
If you can. For acute symptoms like fluid overload, doctors use diuretics and tell patients to restrict fluid and sodium. Antiarrhythmics might be needed for abnormal rhythms. For chronic issues like damage to the heart muscle function, medications that reduce the heart's workload are key things, like ACE inhibitors or beta blockers can help improve systolic function. Digitalis might be used sometimes too.
And are there specific recommendations for screening survivors, like checking their hearts even if they feel fine, especially if they had high-risk treatments?
Yes, definitely. The source provides clear recommendations for routine screening for asymptomatic heart muscle dysfunction, particularly for survivors known to be at high risk because of their past treatment.
Who falls into that high-risk category?
It includes anyone who received a cumulative anthracycline dose of 250 millimeter or more.
Okay, that's lower than the 450 number you mentioned earlier for the 5% risk.
Right, the screening threshold is lower. Also, anyone who received 35 gray or more of radiation to the chest area that included the heart, or anyone who had a combination of those therapies, even at lower doses.
Got it. And what's the recommended screening test?
An echocardiogram, the heart ultrasound, is the recommended tool. Surveillance should start no later than 2 years after the exposure to the toxic therapy ended, and it should be repeated at a minimum of every 5 years throughout the survivor's life.
Every 5 years, lifelong. That's a serious commitment to monitoring.
It reflects the lifelong nature of the risk for some of these effects.
Okay, that's a really comprehensive look at the cardiovascular risks. Let's shift focus now to pulmonary dysfunction, how cancer treatments can affect the lungs over the long term. Radiation seems like a big player here, too.
It certainly is. Radiation therapy to the chest can cause significant lung injury, known as radiation pneumonitis. It typically presents in sort of 2 phases.
2 phase.
Yeah. There's an acute phase, often appearing maybe 4 weeks or so after treatment starts. That's mainly an inflammatory response. This can then evolve into pulmonary fibrosis, which is scarring of the lung tissue in the late phase, and that fibrosis is often irreversible.
Scarring again. Who is most at risk for this radiation pneumonitis?
Several factors increase the risk: advanced age, a history of smoking, poor general health or performance status, having pre-existing lung issues.
Makes sense.
And crucially, the volume of lung tissue that was included in the radiation field and the total radiation dose delivered.
Which cancers typically involve chest radiation?
It's most commonly seen in patients treated for lung cancer itself, obviously, but also lymphomas involving the mediastinum and breast cancer, particularly when the internal mammary lymph nodes near the sternum are treated. The source does note, though, that the incidence seems to be decreasing with modern radiation techniques that are better at sparing lung tissue.
Is there a specific dose threshold for lung injury?
The source mentions the idea of a threshold, but it emphasizes that the severity of the injury is actually better correlated with the volume of lung that gets irradiated to a certain dose rather than just a single dose number. It's about how much lung gets how much radiation.
Okay. What symptoms or signs might indicate this kind of radiation lung damage?
In the acute inflammatory phase, patients might get a fever, a dry cough, maybe some pleuritic chest pain. That's pain that gets worse when you breathe in. On exam, a doctor might hear fine crackling sounds in the lungs, sometimes called velcro-ralis.
Velcrolis, okay. And on scans?
On imaging, like a chest x-ray or CT scan, you often see hazy areas or ground glass infiltrates. These often have relatively sharp edges that correspond pretty well to the area that received radiation, although sometimes the changes can extend slightly beyond the treated field.
How do you measure the functional impact?
The source highlights that a pulmonary function test measuring the diffusion capacity of the lungs for carbon monoxide, the DLCO, is the most sensitive measure of functional impairment from radiation damage.
DLCO. Got it. And what's happening biologically? What's the mechanism?
It starts with a direct toxic effect of the radiation on the lung tissue. This leads to increased permeability of the tiny blood vessels, the capillaries, causing fluid to leak out pulmonary edema. It damages the specialized cells lining the air sacs, the pneumocytes,
Right.
which leads to loss of surfactant, that substance that keeps the air sacs open, and protein leaks into the alveoli. This whole process triggers the release of inflammatory molecules like TNF-alpha, which attracts more inflammatory cells to the area.
So an inflammatory cascade.
Exactly. Then, in the late phase, all that damage and ongoing inflammation lead to the production of reactive oxygen species and increased production of collagen, resulting in that irreversible fibrosis, the scarring. TGF-beta is mentioned as a key molecule involved in fibrosis and may be a potential target for future therapies.
Okay, that makes sense for radiation, but chemotherapy can also harm the lungs, right? Bleomycin is the classic example that comes to mind.
Absolutely. Bleomycin is notorious for its pulmonary toxicity. The mechanism is thought to involve generating those activated free radical oxygen species, but specifically within the lungs.
And how does bleomycin damage look on scans? What are the symptoms?
Radiographically, it often causes diffuse ground glass opacities and consolidation, typically worse in the lower parts of the lungs. Patients might develop a non-productive cough, sometimes with a fever. This toxicity is definitely dose-related, and it's often dose-limiting.
Dose limiting meaning you have to stop or reduce the dose because of it.
Precisely. Similar to radiation pneumonitis, the DLCO test is a sensitive marker for monitoring bleomycin toxicity. The source recommends getting a baseline DLCO before starting bleomycin and then stopping or significantly reducing the dose if the DLCO falls by 25% or more from that baseline.
A 25% drop is the trigger. Are there things that make bleomycin toxicity more likely or worse?
Yes. Several factors: increasing age, having pre-existing lung disease, receiving other chemo agents or radiation that affect the lungs concurrently.
Additive effects.
Right. And also exposure to high concentrations of inspired oxygen. This is important even years later. Patients who have received bleomycin should generally receive the lowest possible concentration of supplemental oxygen if needed, as high levels can trigger or worsen lung injury.
That's a really important long-term consideration. Are there other chemo drugs besides bleomycin known for lung toxicity?
The source lists several others, though maybe less frequent or severe. Mitomycin, the nitrosoureas, doxorubicin when combined with radiation, the combination of gemcitabine and weekly ditaxelone, methotrexate, and fludarabine are mentioned. Also, high-dose chemotherapy, especially with alkylating agents like cyclophosphamide, ifosfamide, and melphalan, particularly in the setting of hematopoietic stem cell transplantation, sometimes combined with whole-body radiation, can cause severe pulmonary fibrosis and a condition called veno-occlusive disease in the lungs.
So how are these chemo or radiation-induced pneumonitis issues managed? Is it similar?
Generally, yes. Both radiation-induced lung injury and most chemotherapy-induced pneumonitis, with the notable exception of toxicity from nitrosoureas, tend to be responsive to treatment with glucocorticoids or steroids.
Steroids again.
Yep. Prednisone is often given, maybe around 1 milligram per kilogram of body weight, for acute symptoms and potentially to prevent progression. The source suggests a slow taper, maybe over about 12 weeks.
And managing steroid side effects is important with long tapers.
Absolutely crucial. Protecting the stomach, managing blood sugar, infection precautions, and importantly, preventing or treating osteoporosis because steroids leach calcium from bones. Supportive care also includes antibiotics if there's suspicion of infection, bronchodilators if needed, using the lowest necessary amount of oxygen, diuretics for fluid, and often consulting a pulmonologist.
What if it comes back after the steroids are tapered?
If the pneumonitis relapses, the source mentions it might respond to other immunosuppressants like azathioprine or cyclosporine.
And if it progresses all the way to fibrosis, the scarring.
Unfortunately for established pulmonary fibrosis, there's currently no effective therapy that can reverse the scarring. Management becomes primarily supportive, relieving symptoms, providing supplemental oxygen as needed. Experimental targeted anti-inflammatory agents are being looked at, but nothing standard yet.
Is there anything to prevent it? besides careful radiation planning?
The source mentions amifostine, a drug that scavenges free radicals. Some studies showed it reduced the rate of radiation pneumonitis, but its use is pretty limited by significant side effects, especially bad nausea and low blood pressure.
Okay. What about the newer agents, targeted therapies, and immunotherapy? Do they hit the lungs too?
Pulmonary toxicity from these newer classes is generally less common than with something like bleomycin, but when it happens, it can be severe and potentially life-threatening. It often requires permanently stopping the drug.
What kind of lung problems do they cause?
Non-infectious pneumonitis inflammation not caused by infection characterized by cough, difficulty breathing, infiltrates on scans. This has been reported with various targeted agents.
Oh, which ones?
The source lists sunitinib, sorafenib, EGFR inhibitors like cetuximab and afatinib, crizotinib, PI3K inhibitors like idelalisib and copanlisib, and MTOR inhibitors like everolimus and temsirolimus.
It's quite a few different classes.
It is. Additionally, the antibody-drug conjugate brentuximab vedotin, that's an antibody linked to a chemo agent, can cause severe pulmonary toxicity, especially when combined with other chemo, particularly bleomycin. That combination is generally avoided now.
And the rule is, if severe pneumonitis develops with these newer agents.
Permanent discontinuation is typically necessary. You usually can't just lower the dose.
Got it. Okay, that covers the respiratory system well. Let's move on to a broader but critically important area. The immune system and the associated risks of second malignancies and just impaired long-term immune function.
This is a really major area of concern in survivorship care. Most cancer treatments, almost by definition, are designed to kill rapidly dividing cells, and that includes many cells of the immune system.
Right, collateral damage.
Exactly. This causes what we call hematologic toxicity damage to blood-forming cells, and it has cumulative effects on the host immune system over the long haul. A key consequence of this is a significantly higher risk of developing a second distinct cancer later in life.
A second cancer? That sounds terrifying.
It is a major concern, and the source emphasizes it's a major cause of death for some groups of cancer survivors. For example, survivors of childhood cancers, despite their high initial survival rates, face about a twofold increased risk of developing a solid tumor later in life, especially after age 40, compared to the general population.
Twofold risk. And what determines that risk?
It's complex. It's an interplay of multiple factors. The patient's age at treatment, their sex, environmental exposures like smoking, which might have contributed to the first cancer and increases risk for others.
Sure.
Their underlying genetic susceptibility. Some people are just born with genetic syndromes that predispose them to multiple cancers, and of course, the specific treatments they received.
So it's not always the treatment's fault. Sometimes it's just underlying risk.
That's right. The source points out that survivors might still be at higher risk for certain cancers simply because they had a related first cancer. Like a lung cancer survivor, often linked to smoking, being at higher risk for other smoking-related cancers like esophageal, head, neck, kidney, or bladder. Or a woman treated for breast cancer having a higher risk in the other breast. Or Hodgkin lymphoma survivors having an increased risk for non-Hodgkin lymphoma later.
You mentioned genetic syndromes predisposing people to cancer even before treatment.
Yes, that's an important distinction the source makes. Certain inherited genetic syndromes drastically increase a person's lifetime risk of multiple cancers. Examples include MN syndromes, Lefraumeni, Lynch syndrome, Cowden-Gardner syndrome. These cause genetically based second malignancies, but the treatment isn't the primary cause in those specific syndrome-related cases.
Okay, but there are genetic conditions that do increase treatment risk.
Yes. There are other genetic disorders where the problem is faulty DNA repair mechanisms, things like ataxia-telangiectasia, Bloom syndrome, Fanconi's anemia. These conditions not only greatly increase lifetime cancer risk on their own, but they also make individuals much more sensitive to DNA-damaging treatments like chemo and radiation, significantly boosting their risk of treatment-related second malignancies.
And the risk from the treatment itself, especially when you combine chemo and radiation.
The source is very clear on this. The risk of treatment-related second malignancies from combined chemo and radiation is at least additive and often synergistic.
Synergistic meaning the combined risk is even greater than just adding the two risks together.
Exactly. 1 + 1 = more than 2 in terms of risk here. This really underscores why, when designing treatment plans, it's critical to carefully justify the need for each component. Is both chemo and radiation truly necessary for this patient?
Because the combination significantly ramps up the long-term risk.
It does. Patients treated with combined therapy often need indefinite surveillance programs specifically designed to detect these potential second cancers early. In some very high-risk situations, prophylactic surgery might even be considered.
Let's talk specifically about radiation-induced second malignancies first. How does that risk play out over time?
Radiation carries an increasing and lifelong risk of causing a new cancer. The risk starts relatively low in the first decade after treatment, maybe 1–2%, but it keeps climbing over time. The source suggests it could exceed 25% after 25 years.
25% after 25 years? That's significant.
It is. The risk is dose-dependent, and these second cancers typically pop up within or right next to the area that was irradiated.
What kinds of cancers are common?
Common types linked to prior radiation include cancers of the central nervous system, brain, spinal cord, breast, lung, thyroid, skin, bone, and sarcomas. Those are cancers of connective tissues. Radiation-induced sarcomas can be particularly aggressive and often have a poor prognosis.
Does age or sex matter for radiation risk?
Very much so. The source gives a powerful example for breast cancer risk. For women treated with just radiation over age 30, the increased risk is relatively small, but for women treated under age 30, the risk increases dramatically about 20-fold.
20 times higher risk if treated young.
Yes. A specific statistic cited is that a 25-year-old woman treated with mantle radiation for Hodgkin lymphoma that covers the neck, chest, armpits has an estimated 29% actuarial risk of developing breast cancer by the time she's 55.
Nearly a 1 in 3 chance by middle age. That's staggering. Okay, what about chemotherapy-induced second malignancies? What are the main risks there?
Chemotherapy is most strongly associated with two particularly devastating types of second blood cancers: acute leukemia and myelodysplastic syndromes, or MDS.
Leukemia and MDS.
Right. The source details two main categories of treatment-related leukemia. One is linked to chronic exposure to alkylating agents, especially when combined with radiation. This type of acute myeloid leukemia, AML, often has specific chromosome abnormalities like deletions in chromosomes 5 or 7 and complex genetic changes. It's frequently preceded by a period of MDS.
Okay. What's the risk level and timing?
The lifetime risk is estimated at 15%, and it's increased by older age at treatment and concurrent radiation. The incidence typically peaks about 5 to 8 years after treatment, but then it decreases, getting closer to baseline risk by about 10 years out.
And the second type of AML?
The second type is associated with a different class of chemo drugs called topoisomerase inhibitors. This AML has different genetic hallmarks, often specific translocations involving chromosome 11q23. Its incidence is lower, generally under 1%. It tends to occur sooner after treatment, usually 1.5 to 3 years, and it rarely follows a period of MDS.
Are these treatment-related leukemias treatable?
Unfortunately, the source highlights that both types are largely refractory to standard leukemia therapy and carry a very high mortality rate. They are very difficult to treat successfully.
That's grim. And MDS itself is a risk, not just as a precursor to leukemia.
Yes, the risk of developing MDS is increased after chemotherapy, and these cases often progress to acute leukemia, again with a very poor prognosis. The source also briefly touches on age-related clonal hematopoiesis. This is where older people spontaneously develop mutations in their blood stem cells unrelated to treatment. It speculates that chemo might increase the risk of these clones progressing to a myeloid malignancy, but the mechanism isn't fully clear from the text.
Are other chemo drugs linked to second solid tumors besides the blood cancers?
Yes. Bendamustine, a relatively newer alkylating agent used often in lymphomas, has been shown to cause significant long-term suppression of B and T immune cells, lasting potentially for years. Long-term studies show higher rates of death specifically from second malignancies in patients treated with bendamustine regimens compared to other standard regimens.
Okay, what else?
Purine analogs like cladribine and pentostatin cause profound, long-lasting T-cell suppression. Alkylating agents in general, besides leukemia risk, are linked to increased risk of solid tumors like thyroid, lung, breast, bladder cancers, and sarcomas. Cyclophosphamide's risk for sarcoma and breast cancer is described as dose-dependent.
Any others?
Procarbazine and platinum agents have been linked to GI malignancies. The hormone therapy tamoxifen, used widely for breast cancer, carries a small, maybe 1–2% risk of endometrial cancer after 5 or more years of use. But the source notes surveillance is effective, and the risk is low compared to tamoxifen's benefit against breast cancer recurrence.
Right, risk versus benefit.
Exactly. Finally, immunomodulatory agents like lenalidomide, used often in myeloma, carry a significantly increased risk of second hematologic malignancies, lymphomas, leukemias, especially in patients who previously received alkylating agents like melphalan.
Wow. Given this huge list of potential second cancers from different treatments, surveillance must be a massive part of survivorship care.
It is absolutely crucial. The source states flat out that indefinite surveillance is necessary for survivors at risk, and it gives several specific examples of recommended surveillance based on these risks.
Like what?
For breast cancer risk after chest radiation, mammograms, potentially with breast MRI, should start at age 25 or 8 years after finishing radiation, whichever is later, and then continue annually.
Annually from a young age, potentially.
Yes. For any organ that was in a radiation field, there's increased risk. So chest radiation increases gastric or esophageal cancer risk. Abdominal or pelvic radiation means annual colonoscopy starting at age 35 or 10 years post-exposure, whichever's later.
Colonoscopy starting at 35, potentially.
Mhm.
What about neck radiation and thyroid risk?
For neck radiation survivors, while the source doesn't cite formal population screening guidelines beyond clinical exam, any palpable thyroid nodule needs a fine needle aspiration, and periodic TSH blood tests are needed, both to detect hypothyroidism and because high TSH might stimulate thyroid cancer growth.
Okay. And for those at risk of the treatment-related leukemias or MDS?
For patients who had alkylating agents or topoisomerase inhibitors, the recommendation is a complete blood count, CBC, every 6 to 12 months.
Checking blood counts regularly.
Yes. And if the CBC shows anything worrying, low counts, cytopenias, abnormal cells on the smear, large red cells, macrocytosis, that should trigger a full workup with a bone marrow biopsy and aspirate, including genetic tests, flow cytometry, FEH studies to look for early signs of MDS or leukemia.
So very specific surveillance based on the treatment received. Beyond causing second cancers, how does treatment affect the immune system's general ability to function day to day, fight infections, prevent autoimmune problems?
Combination chemotherapy regimens are broadly associated with impaired immune health over the long term. This isn't just about second cancers, it leads to an increased risk of opportunistic infections, ones that wouldn't normally affect healthy people, a higher incidence of autoimmune complications, and generally weakened protection against various bugs.
Can you give some examples?
Sure. Survivors of lymphoma, for instance, have elevated risks of developing autoimmune hemolytic anemia, where the body attacks its own red blood cells, various viral or fungal pneumonias, meningitis, and other infections. And these risks can persist for decades after treatment.
Decades later, still higher infection risk.
Yes. Certain treatments have very specific immune impacts too. Treatments that severely deplete T cells, like anti-thymocyte globulin or certain T cell targeting antibodies, increase the risk of EBV-associated B-cell lymphoproliferative disorders. That's uncontrolled B-cell growth triggered by the Epstein-Barr virus. The source notes these often resolve if the immunosuppression is stopped.
Okay.
Then you have agents causing long-term B-cell aplasia, basically, a persistent lack of B cells. This includes anti-CD20 antibodies like rituximab, B-cell targeting CAR T therapies, bispecific antibodies, and sometimes immune checkpoint inhibitors. These patients often need regular IVI infusions.
Intravenous immunoglobulin.
Right, to get antibodies passively. And they need constant vigilance for infections, especially sinus and lung infections. Another issue mentioned is late-onset neutropenia, low neutrophils, appearing months after exposure to drugs like rituximab or immunomodulatory agents, which often requires growth factor support.
So managing immune health and preventing infections is a lifelong concern for many survivors.
Absolutely. Given these risks, the source recommends all cancer survivors get an annual flu shot. And they should be considered for a pneumococcal vaccination too, based on their age and immune status, following standard guidelines.
Okay. Let's shift gears again, this time to reproductive and endocrine dysfunction. These seem like particularly common long-term effects, especially for younger survivors.
They are indeed highly prevalent. Endocrine or hormonal complications are very common, especially in childhood cancer survivors. The source says nearly half of childhood survivors will experience at least one hormonal disorder in their lifetime. And many of these are late effects, only showing up years or decades later.
Half of childhood survivors. Wow. What treatments pose the biggest risk here?
The highest risk for endocrine problems comes from radiation therapy to the head, neck, or pelvis, or from certain chemo agents, particularly the alkylating agents again.
Let's start with radiation to the gonads, the testicles, or ovaries. How sensitive are they?
Radiation can significantly impact both. Sensitivity does vary with age. For males, sperm production, spermatogenesis, is very sensitive. Doses as low as 600-700 ctg can cause permanent azoospermia, a complete absence of sperm.
600 ctg can wipe out sperm production.
Potentially, yes. But Leydig cell function, which produces testosterone, is much more resistant. You typically need doses below 2000 cg to significantly impair testosterone production. So fertility is lost at much lower radiation doses than hormone production in males.
Interesting distinction. What about erectile dysfunction?
That's common too, especially in men treated with external beam radiation for prostate cancer. Up to 80% might experience it, though drugs like sildenafil can often help.
And for females, how does radiation affect the ovaries?
Ovarian damage from radiation is very age-related. Prepubertal ovaries are more tolerant, but after puberty, they become increasingly sensitive. Doses of just 150-500 cgg Shay can significantly impair ovarian function. And even if menstrual cycles return after treatment, there's a significantly increased risk of premature menopause compared to the general population.
Managing these hormone deficiencies, especially if the original cancer was hormone sensitive, sounds tricky.
It really is. Hormone replacement therapy, like estrogen for women with premature menopause, is often contraindicated, meaning it shouldn't be used in survivors of hormone-sensitive cancers like ER-positive breast cancer.
So what do you do then?
The focus shifts to managing the symptoms of hormone deficiency with non-hormonal methods. Things like paroxetine, clonidine, or pregabalin might help with hot flashes. And crucially, you have to pay close attention to bone health.
Because low hormones affect bone density.
Exactly. Low estrogen or testosterone leads to bone loss. So ensuring adequate calcium and vitamin D intake, considering bisphosphonate drugs if needed, and monitoring bone density with DEXA scans becomes really important.
What about radiation to the head or neck area? What endocrine problems arise there?
Radiation to the head, especially cranial radiation used for brain tumors or CNS prophylaxis in childhood, can have wide-ranging endocrine effects. It can mess with leptin biology, contributing to obesity. It commonly causes growth hormone deficiency,
Leading to
reduced strength, lower exercise tolerance, decreased bone density. It can disrupt the entire pituitary hypothalamic axis, that central control system for many hormones, leading to a whole array of potential endocrine abnormalities that clinicians need to be suspicious of.
Is cranial radiation still used much?
The source points out that the decline in using prophylactic cranial irradiation for leukemias and lymphomas has actually been beneficial in reducing these specific late endocrine effects. Neck radiation obviously risks damaging the thyroid gland.
Causing what thyroid problems?
Hypothyroidism, underactive thyroid, Graves' disease, overactive thyroid, thyroiditis, inflammation, and even thyroid cancers later on. That's why routine TSH monitoring is recommended both to catch hypothyroidism early and also to keep TSH levels suppressed, as high TSH might theoretically drive thyroid cancer growth.
And abdominal radiation.
For survivors of abdominal radiation, the source recommends annual screening for obesity and diabetes, checking height, weight, and getting a hemoglobin A1C test at least every couple of years.
Okay, so radiation's impact depends heavily on location. And what about chemotherapy and its link to fertility issues? You mentioned alkylating agents.
Yes, alkylating agents are the chemo drugs most strongly associated with both male and female infertility. This toxicity is related to the specific drug, the cumulative dose, how long treatment lasted, and importantly, the patient's age at treatment.
Age matters a lot here.
Yes. Generally, prepubertal patients, both boys and girls, tolerate the gonadal effects of chemo better than postpubertal patients.
Yeah, the effects.
In females, alkylating agents increase the risk of ovarian failure. Even if periods come back, the risk of premature menopause is still higher, and it's age-related. For males, lower-intensity regimens might cause temporary reversible azoospermia. But high-intensity therapy, like for stem cell transplants, and high cumulative doses of drugs like cyclophosphamide over 9 grams per square meter as mentioned, are strongly linked to long-term or permanent infertility.
This really underscores how vital it is to discuss these reproductive risks before starting treatment, doesn't it?
Absolutely essential. The source emphasizes counseling all patients about the potential impact on fertility. And when it's feasible and appropriate, timely referral for fertility preservation is key sperm banking for males, egg or embryo freezing for females. Assisted reproductive technologies can then be very helpful later on.
You mentioned bone health earlier regarding hormone levels. Can cancer treatment directly impact bone density too?
Yes, combination chemo regimens can directly impair bone health, especially in older patients who are already more susceptible to bone loss. Add chemo effects and potential hormone issues, and the risk of fractures goes up significantly.
How high?
The source mentions that in patients over 70, within 5 to 10 years of finishing therapy, the fracture risk could be as high as 5–10%. Specific high-risk groups for low bone density include survivors of pediatric ILL and CNS tumors, and anyone who's had a hematopoietic stem cell transplant.
How do the newer agents fit into the endocrine picture? Immunotherapy and targeted therapies.
Immune checkpoint inhibitors, by revving up the immune system, can sometimes trigger autoimmune attacks on endocrine organs. The thyroid and the pituitary gland, specifically the adenohypophysis, are common targets.
Causing hormone deficiencies.
Exactly. Hypophysitis, inflammation of the pituitary, is more common with CTLA-4 inhibitors. Thyroid dysfunction, either hypo or hyperthyroidism, is more frequent with PD-1 inhibitors. These can happen anytime, during or after treatment, and usually require lifelong hormone replacement if the gland is destroyed. Early recognition is crucial.
And targeted therapies like TKIs.
Tyrosine kinase inhibitors also have known endocrine effects. Imatinib, used for CML, has been linked to slower growth in children, especially before puberty, possibly by disrupting growth hormone signaling. Other TKIs have been associated with altered bone remodeling, lower calcium vitamin D, thyroid issues, gonadal dysfunction, adrenal problems, altered glucose metabolism, secondary hyperparathyroidism. It's a mixed bag.
So monitoring is needed there too.
Yes, periodic thyroid function tests and replacing hormones or vitamins as needed while patients are on these long-term therapies.
Okay, let's move on to neurologic dysfunction. This feels like another area with potentially really significant and maybe irreversible long-term impacts.
It is. And the source notes that the incidence and severity of neurologic problems related to cancer treatment are actually increasing.
What is that?
Several reasons. Better supportive care lets us give more aggressive treatments. We're treating older patients who might be more vulnerable. Treatments sometimes go on for longer durations, and simply we have more long-term survivors who are alive long enough to develop these late effects.
What are the underlying mechanisms? How does treatment damage the nervous system?
It's diverse. Direct damage to myelin, the nerve insulation, damage to glial cells, the support cells, damage to the neurons themselves. Treatment can also alter the cell's internal structure and transport systems, affect cell metabolism, and maybe even accelerate cellular aging, like telomere shortening, particularly with radiation.
Who is most at risk for these long-term neurologic effects?
Survivors of central nervous system tumors face the highest risk for late-onset neurocognitive impairment. This isn't just one thing, it's a range of difficulties.
Like what?
Impaired general intelligence, slower thinking or processing speed, problems with executive function planning, problem-solving memory deficits, attention problems. These are seen in childhood survivors of CNS tumors treated with both radiation and chemo.
Let's dive into radiation effects on the CNS specifically.
Radiation to the brain or spinal cord can cause problems on different timelines. Acutely, within weeks, patients might get nausea, drowsiness, sleepiness, coordination problems, ataxia, but these usually recover.
Okay, temporary effects.
Then there's early delayed toxicity, weeks to maybe 3 months out, similar symptoms, often linked pathologically to reversible demyelination. The really concerning ones are the chronic, late radiation injuries. These develop months, years, even decades later, and cause progressive dysfunction over time.
Progressive meaning it gets worse.
Often, yes. Spinal cord damage, myelopathy, is highly dose-dependent and thankfully rare now with modern techniques. There's an early self-limited form called Lermite sign, that electric shock down the spine with neck flexion, usually 6-12 weeks post-treatment, resolves on its own. Peripheral nerve damage from radiation is rare. Nerves are pretty resistant.
What about the brain itself?
Diffuse radiation injury causes global cognitive problems, often seen as white matter changes on scans. Pathologically, it involves small blood vessel changes and focal areas of tissue death, necrosis. The most severe form is necrotizing encephalopathy, almost always seen when radiation is combined with chemo, especially methotrexate.
You mentioned prophylactic cranial irradiation being less common now.
Yes, exactly, because of these significant acute and long-term neurologic effects. It was used to prevent leukemia spreading to the CNS, but the cognitive cost was too high.
How are these radiation CNS effects managed?
Steroids might help symptomatically with acute effects, but don't change the long-term course. Psychostimulants like methylphenidate have shown some potential to improve attention and executive function in childhood survivors with these deficits.
What increases the risk of radiation CNS toxicity?
For kids, being younger at treatment, higher brain dose, larger volume irradiated, longer treatment times. For adults, being over 60 and getting whole brain radiation is a big risk factor. And there's emerging research on genetic variations, genes involved in folate paths, oxidative stress, neurotransmitter processing that might influence individual susceptibility.
Interesting. Okay, chemotherapy is also infamous for causing nerve damage, right? Neuropathy seems really common.
Absolutely. Chemo-induced peripheral neuropathy, CIPN, is very common and often long-lasting. Vinca alkaloids, like vincristine, are classic examples.
How did that typically present?
Usually a stocking glove pattern numbness, tingling starting in hands and feet, potentially progressing to weakness, motor loss. It's highly dose-related. It affects both sensation, pain, temp, position, vibration, and motor function, mainly out in the extremities. Careful assessment during treatment is needed to try and prevent permanent damage, but even mild toxicity can take a long, long time to resolve after stopping the drug.
What about platinum agents? Cisplatin, oxaliplatin.
Also notorious for neuropathy, usually dose-dependent and more sensory than motor. Oxaliplatin is unique. It causes that immediate, acute, cold-induced neuropathy. Symptoms triggered by cold usually resolves hours, days after infusion, but very unpleasant.
Right, and chronic neuropathy.
Both cisplatin and oxaliplatin can cause chronic neuropathy developing months or years after treatment, and it can worsen with more exposure. Cisplatin, especially over 400 millimeter cumulative dose, is linked not just to neuropathy but also hearing loss, ototoxicity, requires hearing tests, audiometry. Carboplatin generally affects hearing less.
Any other chemo drugs with specific neurotoxicities?
High-dose cytarabine can cause cerebellar dysfunction problems with coordination, ataxia, speech, dysarthria, eye movements, nystagmus. Severe cases, encephalopathy, seizures, coma. Drugs related to 5-fluorouracil can cause painful hands and feet, dysesthesias, that's hand-foot syndrome, usually stops when the drug stops.
And methotrexate comes up again for brain effects?
Yes, especially high doses or with radiation. It can cause leukoencephalopathy, white matter damage, acute form, reversible sleepiness, confusion, more common with high doses. 3G emitters may be worse in younger patients. Subacute form, weeks later, helped by steroids. Chronic form, months, years later, progressive, irreversible cognitive loss, focal signs. Definitely worse with radiation, worse if treated younger.
What about the infamous chemo brain, that foggy feeling survivors report?
Chemo brain is definitely a real phenomenon the source acknowledges. It's neurocognitive decline, specifically after chemo alone, without brain radiation, seen notably after adjuvant chemo for breast cancer with anthracyclines, taxanes, cyclophosphamide.
What kind of problems?
Memory issues, trouble learning new things, attention deficits, slowed processing speed. The source says there's no single clear mechanism, no proven effective therapy yet, though exercise might help. Most people improve within about a year after chemo, but maybe 10–20% have persistent symptoms.
So conventional chemo has a wide range of neuroimpacts. What about the newer targeted and immunotherapy agents?
They can cause neurologic problems too, and sometimes worsen neuropathy left over from prior chemo. Proteasome inhibitors like bortezomib are linked to neuropathic pain and motor neuropathy, immediate or delayed, may be related to oxidative stress. Giving it subcutaneously seems less neurotoxic than IV.
Okay. What about CAR-T and similar therapies?
CAR-T and bispecific antibodies can cause significant acute neurotoxicity, confusion, encephalopathy, seizures, cerebellar symptoms. It's often dramatic, thought to be related to the cytokine release syndrome, CRS, and usually time-limited. But a minority do have persistent neurologic dysfunction managed supportively. Steroids help acutely, but the IL-6 blockers effective for CRS don't seem to help the neurotoxicity much.
Are there other unique neuro risks with newer agents?
PML, progressive multifocal leukoencephalopathy, that rare but serious JC virus brain infection, has been reported with immune-suppressing agents like rituximab, ibrutinib, PI3K inhibitors, presents as inflammatory brain lesions. Management is supportive, stop the drug. Other targeted drugs given long-term dasatinib, thalidomide, lenalidomide are also associated with neurologic dysfunction.
And antibody-drug conjugates, the ADCs.
Yes, these novel therapies linking antibodies to potent toxins can also cause significant central and peripheral neurotoxicity. Brentuximab vedotin, pertuzumab are examples. It emerges during treatment, seems dose-dependent. Early recognition and dose interruption or modification are key to keeping patients on therapy if possible.
What about immune checkpoint inhibitors and neuroside effects?
They can cause autoimmune complications, including unique neurologic ones like optic neuritis, optic nerve inflammation, which might be reversible with steroids.
Okay, let's turn our attention finally to the gastrointestinal tract and the liver. Long-term effects there.
Long-term, irreversible liver damage from standard chemo regimens at typical doses is actually relatively rare.
That's good news.
It is. However, a potentially lethal complication is hepatic veno-occlusive disease, VOD, also called sinusoidal obstruction syndrome. This can result from long-term methotrexate use or from high-dose chemo regimens, especially those used before stem cell transplant, sometimes with radiation.
What are the signs of VOD?
Classic presentation is ascites, fluid in the abdomen, without much jaundice, high alkaline phosphatase on liver tests, and an enlarged liver and spleen. Pathologically, it involves congestion of small liver veins, endothelial cell proliferation, liver cell atrophy, leading eventually to fibrosis.
So monitoring liver tests during chemo is important.
Absolutely essential. The source stresses frequent liver function tests during any chemotherapy because both expected and unexpected idiosyncratic toxicities can happen. Some nucleoside analog drugs have also rarely caused liver dysfunction.
Does radiation affect the liver too?
Yes, radiation-induced liver disease can happen. Risk depends on dose, volume irradiated fractionation, pre-existing liver disease, concurrent chemo. Doses over 1,500 cVnc can cause dysfunction, and there's a steep dose injury curve. Clinically, it often looks a lot like VOD.
What about the newer targeted and immunotherapy agents? Do they cause GI or liver problems later on?
Yes, they've introduced a range of late GI and hepatic toxicities. Hepatitis, liver inflammation, colitis, colon inflammation, problems absorbing nutrients, chronic diarrhea. Serious liver injury needing drug discontinuation has been reported. It's often not dose-related, so lowering the dose doesn't help you have to stop. Thought to be T-cell-mediated autoimmune attack, risk higher with combinations.
And diarrhea seems like a big issue with targeted agents.
Huge quality-of-life issue. Diarrhea, sometimes progressing to colitis, is associated with virtually all targeted agents that block signaling pathways, PI3K, BCR-ABL, BTK, EGFR, MEK, CDK inhibitors, immunomodulatory agents. With indefinite treatment, it often leads to stopping the drug if it can't be managed.
Any specific causes or treatments for diarrhea?
The source mentions late-onset diarrhea with immunomodulatory agents like lenalidomide can be due to bile acid malabsorption and often responds to bile acid sequestrant drugs. Immune checkpoint inhibitors, of course, cause autoimmune colitis and hepatitis, often needing prompt steroids, maybe a long taper.
How about the kidneys and bladder? Are they vulnerable long-term?
Yes. Cisplatin is the classic kidney toxin, can cause reversible kidney function dips during treatment, but also severe irreversible damage, especially with pre-existing kidney disease or high doses. It also makes kidneys more susceptible to later insults.
And the bladder. Cyclophosphamide comes to mind.
Right. Cyclophosphamide and aphosphamide are activated in the liver, and a breakdown product, acrolein, is toxic to the bladder lining as it's excreted. Causes hemorrhagic cystitis, bleeding, inflammation, pain.
How is that prevented?
Using Mesna, that free radical scavenger drug, is key. It neutralizes acrolein in the bladder, required with ifosfamide. Long-term, that cystitis damage might also predispose to bladder cancer later.
Do newer targeted or immunotherapy drugs affect the kidneys much?
Generally, targeted agents don't have major direct acute kidney toxicity risks, but several agents cause systemic hypertension, PI3K inhibitors, anti-VEGF agents, FLT3 inhibitors. Over time, that high blood pressure can lead to late kidney effects or progressive decline. Immunotherapy rarely causes kidney dysfunction, but autoimmune acute interstitial nephritis can occur, needing prompt steroids like other immune toxicities.
Okay. Beyond all these physical organ-specific issues, cancer diagnosis and treatment clearly have profound psychological and socioeconomic impacts that can last a lifetime.
Absolutely. The source explicitly addresses this. Survivors are at increased risk for long-term anxiety, depression, attention problems, even post-traumatic stress syndromes related to the whole experience.
And the practical life challenges.
Significant socioeconomic stressors are common. Difficulty with employment, finding jobs, keeping them, discrimination, challenges with health insurance, strains on relationships, financial hardship from costs and lost income, physical or emotional difficulties with intimacy and sex.
It affects every aspect of life.
It really can. Childhood cancer survivors who maybe missed key schooling or social development are noted as being less likely to graduate college or get full-time jobs compared to peers. They might also be more likely to engage in risky health behaviors like substance or alcohol abuse later.
Who is most vulnerable to these psychosocial impacts?
The source indicates the biggest impact is often seen in patients who had treatments directed at the central nervous system brain radiation, intensive chemo that crosses the blood-brain barrier, likely linked to those neurocognitive effects we discussed.
What's the clinician's role here?
Crucial. Oncologists and the whole care team need to explicitly ask about and address these issues, provide counseling, support, referrals. The source notes that while overall suicide risk is low, it is higher in cancer patients and survivors than age-matched controls. Cognitive behavioral therapy tailored for survivors might help improve anxiety and PTSD.
Given this enormous breadth and complexity of potential long-term issues affecting nearly every organ, plus mental health, plus life circumstances, developing comprehensive survivorship care plans seems absolutely vital.
It's considered a cornerstone of modern cancer care. Ideally, it starts at diagnosis and continues indefinitely. Many guidelines recommend every patient get a unique survivorship care plan when they finish initial treatment.
What's supposed to be in that plan?
It should summarize their diagnosis, the specific treatments they got, potential long-term and late effects linked to those treatments, the recommended schedule for surveillance, for recurrence, second cancers, recommendations for monitoring and managing late effects, plus general health promotion advice.
Sounds great in theory. Does it work in practice?
Well, the source notes that while the concept is widely accepted, the hard evidence showing these plans definitively improve health outcomes is still limited, and there are big challenges with resources for actually implementing them consistently for everyone.
Resource limitations. What about surveillance specifically? How do we make sure it's effective but not excessive?
Focused surveillance plans, tailored to the individual survivor's specific risks, are critical for early detection of late effects, hopefully when they're treatable. But the source stresses these plans must incorporate risk stratification. Meaning you assess the specific risks based on that person's treatment history and other factors, so you don't do unnecessary tests on low-risk people. Over-testing wastes resources, leads to false positives, more procedures, and causes significant anxiety for the survivor.
Who should be providing this long-term survivorship care? Is it always the oncologist?
Traditionally, yes. But given the sheer number of survivors now and the complexity, the source says this is a major challenge. It means primary care docs, nurse practitioners, physician assistants, preventive medicine specialists, they all need training in the long-term follow-up and management of cancer survivors in remission. It really needs a collaborative model.
What are the main components of that care?
Surveillance for recurrence, surveillance for second malignancies, and monitoring for all those long-term treatment effects we discussed. Plus health promotion, making sure they get regular age-sex-specific screenings like colonoscopies, pap smears, mammograms, HPV vaccine, DXA scans, and addressing psychosocial well-being. Interestingly, the source notes most recurrences are actually picked up because the patient develops new symptoms, not just from routine scans.
Can you remind us of some specific surveillance examples based on risk?
Sure. Annual mammography after chest radiation, starting maybe age 25 or 8 years post-treatment, whichever is later. Regular thyroid exams and TSH tests after neck radiation. Any localized pain or lump in a radiated field needs imaging. And for those high-risk chemo exposures, CBCs every 6-12 months, with bone marrow workup for abnormalities.
The source mentioned an influential report that helped shape this field.
Yes, the Institute of Medicine and National Research Council monograph called From Cancer Patient to Cancer Survivor, Lost in Transition. It really highlighted the challenges survivors face and proposed that comprehensive care plan concept, informing all clinicians about treatments, risks, signs, symptoms to watch for, and recommended follow-up.
So, looking ahead, what's the overall outlook? What are the biggest remaining challenges in cancer survivorship?
The source concludes it's one of the most significant challenges facing oncology and healthcare today. The goal is always effective treatment with least toxicity. But as treatments get better and more people survive longer, the number needing ongoing specialized survivorship care just keeps growing dramatically.
What's needed most?
More research. We still need to fully understand the underlying biology, the pathophysiology of how these treatments cause long-term harm. We need better ways to identify vulnerable patients beforehand, maybe using genetics or biomarkers, to personalize risk assessment and surveillance. And we need more proven clinical strategies to manage late effects once they occur.
And the field keeps changing.
Constantly. As new drugs and treatment approaches emerge, the types and patterns of toxicities will change too. We need ongoing research and adaptation. Genomic medicine might help personalize surveillance in the future. And critically, the source reminds us, the incidence of many late effects doesn't seem to plateau. They can keep showing up or getting worse decades later.
So lifelong monitoring is really key for many.
Indefinite, lifelong monitoring and care is the reality for many survivors.
We have certainly taken a deep dive today. We've covered an immense amount of ground from the heart, lungs, immune system, hormones, nerves, GI tract, kidneys, all the way to the psychological, socioeconomic impacts, and the whole complex system of survivorship care.
It truly highlights that surviving cancer is, well, it's a monumental achievement, a testament to medical progress, patient resilience, but it absolutely shifts the focus to a new set of complex, lifelong challenges that demand ongoing vigilance, specialized multidisciplinary care, and just dedicated research to improve the lives of these millions of survivors.
It's a powerful reminder, isn't it, that the success of treatment creates this new, often difficult, lifelong journey. And considering what the source tells us, that the incidence of late effects often doesn't plateau, requiring indefinite care, it leaves us with a pretty profound question to think about. As we continue to innovate, bringing in even newer targeted therapies, immunotherapies, how do we ensure that our understanding and management of their long-term impacts keeps pace? Not just for the survivors treated today, but for the millions who will need this specialized, lifelong care decades down the line.